Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and this is session number 156. We have an exceptional teaching case for you today, an elderly male with left main and bifurcation LAD diagonal with the possibilities of using left ventricular support devices, maybe rotational atherectomy, and many teaching pearls for you to understand today. In the meantime, I'd also like to congratulate Dr. Kinney and Dr. Sharma on their excellent 25th anniversary of the CCC Live Symposium, which occurred this week. Absolutely world-class conference, 10 exceptional cases which you would need in your contemporary practice. Again, all complex coronary, left main, bifurcation, calcification, CTOs, antegrade, retrograde, and including what I think are some exceptional cases which are dealing with how do you access the challenges confronting after placement of a TAVR and other devices with the jailed access and compromised access to the coronaries. Today is also the International Yoga Day. And of course, I just reviewed before coming today, and the tremendous benefits of yoga for the patient have been written up in these four prestigious institutions in the last 6 months. At Harvard, at Johns Hopkins, at Oxford, and even in the British Cardiac Society. So the benefits to the patient from yoga are obvious. However, we have an expert here in Dr. Kinney who I think deserves tremendous credit. Probably she has been on the forefront of yoga, the highest, I think, grade amongst any interventional cardiologist in the world. I have personally watched her be a most sincere practitioner of the art for more than 20 years. I recently asked her as to why she felt she did not get COVID, and the straightforward answer was it is probably because of yoga. Now, there is another area where I think Dr. Kinney deserves absolute credit. Of course, today it is fashionable, almost become a fad to talk about yoga and its tremendous heart benefits. But Dr. Kinney is the only and definitely the first and the most prominent physician who has talked about the benefits of yoga specifically for our specialty of interventional cardiologist. I know she practices it each day, and I think the benefits of it for our specialty, where we are bearing the heavy weight of the lead and having 1/3 of interventional cardiologists report problems with the lumbosacral and the cervical area, and so many of us have had discectomy. I did not mean myself. I've been a fairly moderate practitioner of yoga, but I actually credit swimming for having remained healthy. So to have us started today on the International Yoga Day and to demonstrate the benefits of yoga for the interventional cardiologist, I'd like to show you a brief video, Dr. Kinney showing yoga.
So this is a balancing pose, Natarajasana. You can start with what is balance on your left leg. Then what you do is raise your right leg. Losing a little bit of balance is part, but you keep extending your right leg as much as you can, or you are extending your left hand. So same, stay focused, look in the front, and when you're done, just release it.
Anu, such a lovely way to start us on, and also on this yoga day. Samin, Anu, good morning.
All right, good morning to all from our Cath lab. As you said, this is the end of our 13th year. In 2009, this journey we started, and today is episode 156. and the yoga had a lot to do with keep a lot of people healthy in our cath lab. And of course, credit goes to Dr. Keeney, as shown. And we're thankful to all. Yes, the symposium, if we can show the slides, symposium started very well with the 25th anniversary of 15 to 17 with a 300 plus in-person live stream on YouTube, over 1,000 attendees, so very successful. More important is today is the International Yoga Day. And I'll just ask Dr. Keeney to just make some point. She continues to do yoga sessions and so, and a lot of publications on this yoga field. As you mentioned, we did have 3 years ago in December, one time talk about the benefit of yoga, scientific benefit of yoga. And Anu, you want to comment on this?
No, there are several yoga trials showing benefit for patients, especially is it the physical part of it, or is it the mindfulness meditation that helps these patients who have hypertension and also some kind of a metabolic abnormalities. So we actually wanted to do something related to that, because why? Everybody talks about, most of the trials have been done, and the trials have shown that when you practice it for weeks together, yes, it helps in their blood test abnormalities as well as their blood pressure. What exactly happens, why it is better, nobody knows, and that is why we wanted to do the trial called as a SLIM trial. If you see here, yes, this is all to do for patients who have some kind of CAD risk factors, and then we randomize them. They will have baseline microRNA profiling, and then after having done for 16 weeks of yoga versus control is you just tell them, exercise, walking, and of course they have to do other lifestyle modification including diet, and then again we check what happens to the microRNA profiling and to see if there is some change that happens in them if they have practiced yoga. So the trial, actually, if you see here, if you go to the next, we did it was based on the videos. We created a lot of videos. This is my yoga teacher herself, and IRB only approved chair yoga for our patients, and we can track them what they're doing. If they have not done their yoga, or they are not following the protocol, notifications go to them. So this is what it is about. So this is for the patients, and going back to why I practice and why I think it's important for interventional cardiologists is for us, long hours wearing lead takes a toll on the muscle, bone, as well as the ligaments, and everything is taken care in the practice of yoga, where we say it's a dual action. A group of muscle actually contracts and the other group of muscle will stretch. So both are very important, and as we grow older, it's very important that you keep your flexibility, whether it is the hip joint, the shoulders, or the entire spine itself. And that is where this particular practice helps, and I would recommend that most people should try to do it.
Beautiful. So that's a great way to start, segue to our the grand finale of 13 years, and we always update our cases. This is the case which 152, which we tried to do RCA by the antegrade, retrograde technique, everything, but we were unsuccessful. And then Anu brought that patient back. After 2 hours, we decided that time, and we brought the patient 3 months later. And this is the patient done just a few weeks ago, 3 months from there. And you can see supercross and run through and 2 DES. Excellent angiographic result of this failed CTO. So we always say, CTO, you always have to think about getting a booster. If you fail, you bring back, and unless you create a complication. So this is the case that was done very successfully, which we have very few failure in about 155 patients so far. And I would think about 3 of them, and the 2 of them which we came back, and then we did a follow-up PCI on those CTOs. So with that note, great.
Sameen, first of all, I think this point needs to be emphasized here that A failure with the CTO, both antegrade, retrograde, or either or both, does not necessarily represent long-term failure. Several of these people, when you bring them back, microchannels have been created, and it is possible to do it successfully. And I think your case exactly illustrates that, and thank you for showing us this follow-up.
And that exactly happened in that patient, yeah. That there was a micro channel which was so tough to begin with, and there is the wire went in, run through wire, and so. So key is that always, as long as patients are good, you just encourage them to come back. And clearly there is an indication. I mean, indication because this patient has a massive right coronary artery, continues to be symptoms and ischemia. So these are our supporters, and the disclosures, nothing changed. So this is case number 156. The 90-year-old patient came to me out from outside after diagnosed severe 3-vessel disease and left main. Patient has a positive stress test, multiple factors as you see here, also CKD with a creatinine of 1.8 and EGFR of 38. Patient has low EF, 28%, and CABG was declined because of low EF and age. Patient could not give an ACE inhibitor because of high creatinine. Apparently, creatinine bumped up one time to 2.5 after Prinival. So therefore, is not on ACE inhibitor. He's on other good medication and had a 3-vessel disease. So we, with the left main, multiple lesions in the LAD diagonal bifurcation and circ and RCA. So what we did is, I did the RCA PCI a few weeks ago on 5/31. And today we brought this patient back. It was very calcific RCA, require rota plus IVL. As I said, nowadays you don't need to to upgrade the bar. After rota, you still have trouble opening the lesion, do the IVL. And that point we showed by many cases in our symposium. Patient still has a very high residual syntax score. It was 57 to begin with, then still 45 and symptomatic. And that's our goal today. High risk PCI of LAD diagonal bifurcation and left main with a mini crush technique and Impella Assist because of low ejection fraction. This patient will fall into this category, could be R, but after heart team discussion become A. And that is the part of our ACCHA guidelines that once you have discussion, it's appropriate for those patients to proceed. And LV support point of view, this is our common diagram which we always use. In this particular case with the complex PCI, high syntax score, high STS, extensive revascularization, Impella is essential for us to do our good job. Don't cut short. So that's where we are now, and we are going to show this angiogram of this patient, the RCA and the current angiogram. Yep. And we want to show here. Okay. So this is
the E of EDP was 18.
EF actually looks a little better than 25 now. And maybe after the RCA injection. Look at the RCA revascularization.
Excellent job with the right.
Yeah. Yeah.
Very large dominant right coronary artery, and
so you have left main. It's a moderate disease of the proximal circ, and then you have a OM1 moderate size vessel with significant disease, but I think majority of the disease is here in the LAD and a large diagonal. Both are equal size.
Right. There is a one very small diagonal we call diagonal ramus subtotal. But our goal is when in this complex case with this age, we need to concentrate where the money is. Money is in this LAD diagonal bifurcation, and the distal left main, they are 60%, but also need circumflex. Creatinine wise is the issue. So it's okay to take care of the LAD diagonal today, and we bring back for the left main, but then circumflex in the future.
Sameen, just a couple of points to emphasize so that the viewers can be focused on the important parts. As challenging a case as one could have, 90-year-old, I think, quite appropriately turned down for surgery. Very heavily compromised ejection fraction, severe kidney disease, impaired LV function. The importance, I think, what you have mentioned about a support device here is critical, that this is not a case to play games and take chances. Exactly as how they write it, prevent, protect, that's what you need to do in this case. And let's see how you take us through these steps. In the first picture which Dr. Kinney showed, I thought the left main was not bad, but the RAO clearly that demonstrates both you've got, it's a it's a trifurcating lesion, I think, extending from the distal left main to the ostium of the circumflex and the LAD. Modest calcification. I would not call it severe, though. Would you?
Although in the diagonal, so diagonal is more calcified than LAD. Yes, you're right. Otherwise, moderate. But left main, you remember we didn't do too many views now because of the obvious reason, high creatinine. But there is a clear-cut 60+% left main. Actually, in some views, even looks more, even 70. So there is a clear-cut left main disease. So disease is there, and so it goes into that small subtotal diagonal.
Wow.
But we go with this is the LAD now. We need to go to the diagonal first. Diagonal is the one which is a.
Don't keep giving dye. I was there. Don't keep giving dye.
The idea is same, that give very little amount of dye, and this is where the one important point. And so much so in ACC/AHA guideline, which I showed last time. No, that is small. It goes into the small, the subtotal diagonal, which we wanted to leave it, but looks like it's asking for treatment.
Samin, this is a 7 French.
It's a 7 French VL30.
Possibility of two
and single puncture. Single puncture, yes. Definitely, and single puncture, as we showed also during our symposium. So this is where the Impella CP allows you to get a single puncture. So now we are in the diagonal. Get the rotor wire ready. Good. Want to see a little bit?
No.
You are in that small branch. See, remember, within bifurcation, you went into a very small branch. Very early. Here. Good.
Anu, is this a fielder or what wire is it?
Fielder.
Okay.
Wow.
This is it. Good. So use the landmarks. A lot of people use the IVS imaging, but this is not the case. You need the landmarks there. And so this went very easily.
Samin, if somebody could show us the hemodynamics periodically,
show the hemodynamics
demonstrate the
side,
And you have completely abandoned any practice of putting in a right heart catheter for Impella subsequently?
So we actually, so very good point. In questionable cases where hemodynamic compromise, I would say reasonable. We know that National Cardiogenic Shock Initiative, the right heart hemodynamics, right heart assessment is associated with better outcome. What balloon we had? 2.30? So 2.6. So therefore, in other cases, no. As you know, the ongoing PROTECT 4 trial require that the people centered to commit to the right heart monitoring. Then you are doing all cases. So we said no, because we don't do routinely. Yes, as a part of the PROTECT 2 trial, as well as in the SHIELD trial, it was required, so we did it. But clinically, we don't. So I would say very simple, that less to do. Most important is the good hemodynamic assessment, which you need to do. The wire keeps going into that small branch. But yes, if there is a question about the hemodynamics, filling pressures, and so, it's a reasonable to do the right heart. But otherwise, routinely, as you ask, yes, we do not do routine right heart cath measurement. But this question will be, will be answered, that does the routine heart catheter matters. Now, what we require in the PROTECT 4, that if you are leaving the Impella, patient is coming out of the lab with Impella, then you have to put a right heart cath, because that will help in weaning appropriately.
Anu, in the meantime, several people have appreciated your yoga, and one of them writes, you don't need an instructor. You should be an instructor. Samin, another most interesting, I have not seen a follow-up like this. This is a email I got from, I'm not able to read his full name. It's Pavan Palka Rimpu. I'm not. I think there is a full, I'm missing it. But he says that I have a small request, sir. Please make at least 2 live cases in a month. We are working on that, sir. Maybe more than that.
No, but 2 live cases, actually, make sure we have the email. We have at least 4 live cases a month.
Right.
Our coronary cases, at least 3 with the relay. Even next month, we have guaranteed 2. One with our CCC live, and secondly with Sun Pharma. Then I have additional, like even July 1st, we are live related to Brazil. So we make sure we have the email, ask them to send the email, and Kim will put into the email thing. So we will have at least 2 to 3. Let's go. Yeah,
And
minimum we'll say
I
2 to 3.
stand corrected here. The name is Pawan Kumar. Pawan, thank you for getting back to us. I have your email, and we'll get
You'll be
back to
put
you
in the
with
list.
more information.
Yeah, and he'll be put on the list of CCC Live. Anything we do, we actually put under the CCC Live banner. So announcement and everything comes out with the CCC Live banner.
Also,
so they
there
will
is
be
a
also.
question here that can the cases from the symposium be viewed? Yes, you
Yes.
can. All of them are available on our website in full.
No, on the YouTube.
Yeah, yeah, both YouTube and the website. We have to pull back wire a little bit. Yeah, good. Okay, so wire should not be too distal. We go the same technique of taking away the tension.
1.5 bar.
It's a 1.5 bar. Good. Yeah, it's a 1.5 bar. So we did with fielder fine cross first, and then exchange with the rota wire, which is a rota floppy wire.
So there is already, Samin, a question: can this case be done without a rotational atherectomy?
I would say that yeah, probably, but only thing is knowing that how difficult it was right cornering, where I had to use both rota plus IVL. There is a lot of calcium in this case.
I think I would not go there.
Another question,
Stop here.
Which I kind of know your answer, but I think could be still extremely instructional. Why did you choose the right coronary artery first?
Oh, because we thought that this will be a good symposium. Because anytime you work on the left main, left-sided, and if you already have some RCA disease, my goal is always to do RCA first. It'll prepare you better for the subsequent intervention. As you see here, Anu want to emphasize that how the
if you see
body is taking the bend.
If you see the original picture here, you see how the vessel is going up now. You see there the diagonal.
Right.
And we are talking about calcium. You see that I think we can appreciate the calcium there.
Significant calcification, absolutely, no doubt.
So now when I was going up, you see there, I do not want to now make a turn there. This could be a risk of perforation. So we're just going to stop and come out.
Would you consider having or going back with the smaller burr?
No, I think we've got a majority of it. You see that?
Right.
Probably more than half of the lesion. Only the distal, I would say 10% is left. I think the balloon will take care of that.
Yeah, and this is the point I'm trying to make. During the symposium also we did, and I'm the proponent of in a long tortuous lesion, do not go full through.
Absolutely.
So that's where the complication occurs. Do a 2.5 or 3/4 and your subsequent balloon dilatation, because you have cut the interelastic lamina, will take care of it. So we'll show that here now.
I think probably one of the most important teaching cases, whenever you're talking about techniques of rotational ablation, I think also where not to push it through, I think this is a beautiful illustration. In the meantime, Anu, I did notice that during the burring, hemodynamics were very stable.
So you want to do balloon first? What do you want to do now?
Here?
Yeah.
No, let's wire it, right?
Yep.
Question is which wire? Fielder now that we
same fielder wire back.
And that give me a run through for the LAD. LAD we are not going to do anything. I don't think there's a calcium.
Yeah, LAD does not have that much calcium, so let's go with this fielder wire, and then we have the wire for the LAD.
Now, do you want to go there or go exchange with the fine cross? What do you want to do?
No, if you can go with this, let's try.
Then we have this.
Yeah,
side by side.
Go.
Okay.
Side by side. Always question comes that do you want to go to side by side or so? So see that as you've pointed out, a lot of calcium in the diagonal, not much in the LAD. So our goal will be
much more looks to be just at the site of the LAD bifurcation.
Yeah, exactly. Yeah.
But you would not want to rotablate through that ostium of the right there at the it's not the ostium, but
it's
just at the
angulated.
Point.
No, but that's a very angulated. But then it will require that we need a smaller bar. 1.5 maybe a little too big there.
Yeah.
With angulated, maybe 1.25.
Okay. Remember, I wanted to go over the wire here.
Get over the wire system. That's fine.
Yeah. It's a waste of time.
Yeah, better time and die.
Yeah.
Good.
Okay. Forget it.
So, I mean, sometime in the case, I think we need some more guidance, discussion about how long would you keep the Impella in from? Where is it removed? Who removes it? Is it in the cath lab, in the ICU?
Yeah.
And some of those details.
Let's put the area first. This further, yeah. No, very good, important point.
LAD.
So I can tell you. So no,
LAD?
but I know. Let's open that area in case we have to go to the smaller bar. No, we still do not know if we cannot the diagonal. We have to go to a small bar. That's why we have put the fielder wire, and we are going with that now. And then we'll wire the LAD. Now, very important point. I can tell you with the Shield trial, Protect 2, and now Protect 4, we are the lead enroller with 27 patients. Our second person is 11. So we have no cases. No cases, zero. So far, we are done. So in these trials, I would say randomized trials, we have had now over 150 cases, which have been randomized into this high-risk cases, and only one case, which I remember in the Protect 2, where we did change Impella to the balloon pump. Yeah, it's a 2.520. So 2.520 went in, but otherwise everything, we had 2 pre-closed sutures, and everything is taken out in the lab. Now, that's a different than elective. These are for elective PCIs, high-risk PCI. The cardiac shock. In the cardiac shock, 18. Yeah, go a little further. Yeah, 18. No. So cardiac shock, sometimes you may leave it, but not in the elective. So elective PCI invariably will take it out in the
22.
And if required, you may go into leave the balloon pump. So rare cases in an elective situation, not in the trial, when we change it to a balloon pump. But otherwise,
can you go up again so we can see if it's
dilated? What would be your mean duration for the patients with cardiogenic shock?
So cardiogenic shock, some patients we have left it about like 48 hours or so. And of course, many times you escalate to ECMO.
So we see that fully expanded, okay?
Go a little distal also again.
No. Right. You don't need it. That's up to there.
Yep. You have to go further.
Up to there. Yeah. No, go up here. That's good. Okay, down. Now we may have lost, we dilated without wiring.
Exactly the question which came, that would it not have been more appropriate to wire the LAD first?
Yeah. No, but the last dilatation was good. So diagonal, I think we need to go a little further. No, we had to go. No, the diagonal still need a little bit more, and we have to wire that. Yeah, good.
Give me a run through.
Yeah, run through is ready, right? Yeah. So no, but let me, very important point. Why did we not wire? You want to go a little further?
No, that's where we're stopping.
Yeah. Okay, let's see it again. So when the lesion, which we don't have 22 atmosphere.
Okay, down.
Okay, see this now. Let's see, 1 second. Off fluoro, 1 second. Here.
Okay, that's exactly.
So it is just a recoil. Now, the question was very important that why.
You don't think you need to go a little more distal there?
Yeah, I think there's a second time we did, but more important, we'll look into it. But more important question here is that why did we not wire the LAD first? Reason is because we did not go through with the lesion. We were sure, we were confident, but not 100% that we'll be able to crack the lesion. So that's why we wanted to take care of the diagonal, because otherwise we would have gone with the strategy you suggested. Let's go with the downgrade the burr to 1.25. And there clearly in that case, IVL is not option, because if your rotor did not go, IVL won't even make the first turn. Otherwise, the synergy is very good. But in this particular case, in thinking that we might go into 1.25, if we cannot crack the lesion, was the region, now we can take the rotor wire out if you want.
The other thing was, to begin with, we should have probably gone with the 125 burr in the diagonal.
Right.
That could have been another strategy.
That strike me that that's why I asked you there for a moment. I got distracted answering some questions and I had not noticed what size burr you were using. Samin, there was some quite unique observations I had following this year's symposium. Sometimes it strikes you, sometimes it doesn't, and often one is
can you
distracted in the middle. I thought as I reviewed the conference this year, there was far greater discussions about two devices. One I thought, of course, was a continued increased buzz about various aspects of Impella, and the other was shockwave.
Shock wave, yeah.
It was
Good,
quite
good, good.
quite and as you look between the 2 years, I
A lot
think
of grittiness.
the
Is that because just LAD or?
Yeah.
significant awareness, the far sophisticated levels of questions which were being asked, the number of times people were considering shockwave, particularly for expanded stents, I think, which is turning out to be probably, in my mind, one of the most elegant observations. Plus, of course, preparing lesions for structural heart, I think. So a very promising technology, and we are glad to demonstrate its optimal use in many, many cases.
So, and actually it was very interesting in the sense that none cases, because we are so complex, none of the cases we went with the IVL directly. Because people ask how many cases you will go with the IVL directly. I said, depend on what type of patients you have.
Right.
So what type of lesion you have. Okay, let's go up here first. Release it.
Okay, good.
Yeah. So all cases. So what it did is, where you had a trouble, you did a rota, you did a balloon, nothing goes down, bring back the IVL, bring the bigger IVL, and so forth we did. And particularly cases shown by Anu, that right coronary artery using every device, including laser and so. And use of the IVL. IVL, basically, I would say that in my opinion, IVL is going to decrease our complication of rota. Why? Because you are going to be less aggressive and no need for step up bar. Yeah, going up here.
Right. And probably 1.5 being the commonest.
1.5 being the commonest. That is correct.
The balloon opened quite easily, I think, suggesting that maybe there was not much calcium there. And
You have to do fast with this guy. He's waking up. He's moving a lot. No, we did. No, don't get crazy.
Okay.
Yeah, we covered the lesion.
Such an important observation. You know, I often make these remarks in STEMI that, you know, let's get the patient off the table quickly.
See, unnecessary, we dissected them.
Yeah, but that's good. Yeah, a lot of dissection in that LAD, which we expected, because this is a balloon only. And there's another case which showed there was a trial we called DART, D-A-R-T, very late 90s, when a small vessel, we did rota versus PTCA, and we found that time stent use was just coming up. We found that clearly rota causes less dissection compared to PTCA. We have the clear-cut documentation now. What do you want to do now? Quickly.
So for the diagonal, let's go 2.5, I don't know, with the 28, we'll make a turn there, right?
Okay. Yeah.
And then LAD?
LAD
in the
2.75?
Yeah.
You don't want to...
2.5, 38.
There is a fairly diffuse disease in the segment after that dissection too, no?
Where?
No, this is, I think, is part of the dissection.
Which vessel?
Yeah. In the
LAD.
LAD.
No, it was, listen, it was
Maybe-
not, that's why I did not want to go
maybe-
further.
Maybe a touch of bridging
but it
there
is-
also,
that-
but there is some disease there.
No, not go further. Dissection has occurred at the tightest lesion of the LAD. Remember 12 o'clock. The
No,
dissection has occurred, which is okay. This is the diagonal stent.
Was this
28.
a 2.528?
Diagonal. Yeah, 2.5, 28 Xience, and we'll take LAD where the 38 will go. That's the
Right.
question.
Right. 3 no?
2.5 or 2.75? 2.75, and then we can post dilate. And we have the
It
IVS to
looks
show.
2.5.
Yeah. You want to get 2.5, 38? Which
Yeah.
is fine. We can
2.5,
always,
38.
yeah, 2.5, 38.
Proximally we can post,
Yeah,
distal
we
is
can-
not.
Yeah. The only question is whether 38 will go, but
Yeah.
anyway, we'll try.
Let's see.
This is the Xience sky point, and we do the same which we did other side. So right now it's going 2.5, 28 into the diagonal.
So, Samin, the fact that so many
And let you pull back also.
devices have easily gone through balloons, now hopefully we'll know with the stents through that distal left main, does that give you some feeling that maybe that lesion is not critical? I don't, it's not a scientific or a image guided answer, but
No, but
sometimes you
remember
get
our
that-
goal was, very important point. So our goal was to do imaging in the end with the IVS we are ready. So that will tell us lumen of less than 6 or more than 6. So now even in the diagonal, it is not coming. So now question is, do you want to use a
Do you want to anchor in the LED and get
or
this
score
down?
flex, or what do you want to do?
Give me a balloon,
Okay.
2.512 or 2.7512. Let me go anchor
Okay,
in the LED and get this down.
fine. Yeah,
2.512. 2.7512. Not high pressure, regular.
Yeah. So key is that yes, we will have a chance to demonstrate that left main, and you are right. If left main is more than 5.5 even, I would say, not necessarily 6, it's okay to leave it. What we are going to achieve here is the symptom relief, not the survival. Because he has gone through all the survival at age of 90. So goal is to make it symptom free. That is the goal. So with that,
And
if the left main is even more than just 5.5 plus, I will be okay to follow your suggestion that do nothing to the left main.
And in your cases, I think at least 3 or 4 I clearly remember of the 10 cases which were done.
Yeah.
Pretty ample use of guide extension catheters.
Right. Yes.
Become almost
So
a frontline strategy.
Yeah. So rather than struggling, trying to back and forth push the guide, and so it's reasonable to do. Okay. So we're doing a 2.7512. In balloon in the LAD, we are going to anchor it, try to put a stent into the diagonal. So here 14 atmosphere and went in.
Good.
See that? Yeah, good.
You saw the anchor technique?
Yep.
Excellent, excellent demonstration.
Now that was just to show. Now you want to
I'm
dilate the
glad glad you did not proceed on to a guide extension with that
Go
left
here.
main.
LED.
Yeah, because of the left main, yes.
Excellent.
So we are preparing the LED, so the 33 should make a turn there.
38,
Perfect.
38.
So the
38.
balloon there not only helped
Go
you
here. Go here.
getting the stent into the
Yeah,
diagonal,
no need.
but
Okay, down.
also
Okay,
preparing for
38
the
now.
LED.
Yep. 2.538 stent is ready for the LED.
Risk for us is
Yeah, good.
okay. You had once asked me, Samir, about the algorithm, how to do which technique where. What happens in the human brains? How, right? We have so many techniques, but which technique to use and which wire to use, so that's one thing that will work.
Absolutely. You know, it's as we talked today about, you know, you kind of very briefly went through the again, this is not I'm taking the algorithm to a totally different level of discussion. When you mentioned about the benefits of yoga, I've to me there has never ever been any doubt that the far greater benefit is to our minds and to our brains. And you know, often when one talks about
No, good.
its benefit for interventional cardiologist, I think just
what if it's
having a clearer
back,
mind.
Yeah, 2 millimeter.
this is
Diagonal,
back?
yeah, no, that is true. And I think that's where the messenger RNA and maybe check endorphins and all that. Yeah.
Yeah, I'm surprised
Ready?
though.
Some
Anup,
die. I want to-
we'll talk about it at a different, less important part of
Yeah,
the
cop.
case.
Yeah.
No. Yeah, first this. So clearly it's a mini crush technique. This is the
You
2.5.
didn't want to come just another millimeter or two back
No,
with
No,
the
I think we are
diagonal
good.
one?
A millimeter, 1 millimeter is good.
Remember
Yeah,
we showed in our symposium and we had a bat on the OCT.
Nano crush
because
is good enough.
Dr. Roxana Maran felt that I missed it. I said, no, reason is don't bring too much. You'll crush more because once you're going to open the LED stent, remember LED stent will become 1.1.
Some die.
Absolutely.
So
It's not 1. It will become 1.1.
Okay, good.
Yeah.
Completely agree.
That's the key. Yeah.
Now, you think we should pull back the LED a little
No,
bit?
no.
Which
Then
is
comes the left leg.
really,
Good
it is
cop.
Yeah.
this 1 or 2
You have to go this
millimeter
flat.
micro control in a mini crush, which I think defines not only an acute but also
2 millimeter
long-term
first.
results.
First 130. Yeah. To 16. And this one we select the balloon 2.7520.
For
and
which
maybe,
one? LED? I don't know
2 of
whether to make
complete.
it.
Go 2 millimeter. This you have to go a little further. Balloon we
Why
had to
don't
do.
we look at it?
No,
It
no,
looks
that's
good.
okay. Go a little bit further.
It's not
we
going
can
to
go. Yeah. No, go 1 second. We have to do distal edge massage. Go.
We are
Advance
going
this
to
little
do with
bit.
the other
no,
one, no?
But let's see if we can go this one.
It's not going to go, SS.
Okay.
I'm not wasting my time with this.
Okay. So
Well, as it is, I think a balloon, the stent balloon is hardly as tractable as the.
Throw this away.
Anu, the question which I had listening to your design of the SLIM trial, why only 6 weeks?
No, 16 weeks.
why I don't know why I thought even 16 weeks. Even that looks.
No,
But
what more?
16,
No,
okay.
actually, any kind of microRNA changes can happen within hours.
Right.
But to show the difference in their other metabolic parameters, I think 16 weeks is good enough.
You
Even
know, the
getting them to do that, yeah.
British study which Samin mentioned, that was actually, it's very different than all the other studies in which the editorial mentioned that the benefits are at most modest. So I think a lot more investigation in this area, and I would love to see something designed as to the benefits for interventional cardiologists, specifically in their, some kind of, I think it would begin with the questionnaire. Have people considered it? Are there people who are practicing it? Have they seen benefits?
Questionnaire is very easy. We can always send it.
Yeah, I think that would be a nice beginning, Anu.
Go to. Yeah. You're there in the diagonal. But you need a little balloon support because there will be a crush.
This is what, is this a
Same
run through?
fielder wire?
Same fielder.
Fielder.
Run through is in the LAD.
It was the same wire or a new one?
Same wire. Same wire.
Which has the memory, hopefully. And
we always believe in that, yes. Okay, now question is first, you're not going to go with the other balloons. So 2 or 12 or 1.5, 12, whichever your preference is.
2 or 12.
Anu's preference is 2, my preference is 1.5. But yes, you go with the first compliant balloon before you start doing those kissing and non-compliant here. So right now we're ready with the 2.
So there's a lot of discussion about distal proximal, how you recross. Remember, it's a big thing without any randomized trial data. But in the complex cases like this, getting a wire across itself is very hard.
Yeah.
Forget proximal or distal.
Good. Okay, so this is the 2/12 compliant balloon, and we get ready with the 2.75 or what? We have to
27515.
Yeah, that's fine.
I don't know if it'll make a turn.
Okay. LED, it will make a turn in the LED floor.
Okay, give me. Used balloon, right?
No, but this one comes out.
You want a 2.5 high pressure then?
Yeah.
Okay,
definitely.
go high pressure.
Or the diagonal.
Yeah, go 120. Yeah. I went 20 already.
Okay, good. Down. So 2.5 high pressure and a 2.75 for the LED.
Yep.
So far we haven't taken any picture.
Yeah, we don't need.
Okay,
don't
good.
Need yet.
After that we are done. You see, there is a lot of movement with the patient, and I think that's another thing I always want to teach is in complex cases, have your strategy. Unless there is any problem or some complication, just stick to that and try to finish it fast. When patients start being uncooperative, I know now there is more, I think, data that complex cases do the cases under MAC. But for a lab like this, with a high volume, our nurses are so good. They almost trained like, CRNAs. Will here, right?
It's present in many of them. Pablo, other side, there are many of
our nurses are so well trained. Yeah, don't connect.
Totally unrelated question, but I know it is a major issue in cardiac cath labs around the country. Issues related both to personnel shortage, nurses, technicians.
Go negative.
Which balloon
2.5. Yeah.
Supply chain issues with the shortage of devices, shortage of radio contrast agent.
High pressure balloon.
Yep. No, everywhere. No, we are not immune to. Everywhere they're happening. Yeah. Everywhere happening the shortage issue.
2512 high pressure.
So Pawan from India in Andhra Pradesh mentions that even being a cath lab technician, he has found our videos very beneficial, and he's reviewing several of those on our websites and the YouTube. Very good, Pawan. We have always said that benefits of our very sincere endeavors which we have been making for it goes beyond 14 years today. They are not necessarily only for fellows in training or interventional cardiologist practitioners. I think nurses, cath lab technicians, cardiothoracic fellows. This is all a very sincere academic educational efforts to train people.
Yep, absolutely.
And our
particularly our
specialty,
apps,
yeah, we'll come to that, Samin. I'm glad you mentioned it. We'll let Anu and you address it. But look, this is a specialty which was all starting from the time of Dr. Grunzig. It's the live cases which are the absolute tenets of our continued education. You can only read that much in a book, although the apps today, I think, are becoming absolutely extremely beneficial, very easy to follow through. You can even follow an individual case by opening an app and
take a picture first, and then if it's good, we go down. So we'll leave it. I think it'll be fine. Okay, ready? Yeah.
Okay, so the first
we are going to do a final IVUS.
Yeah, there we go. Gorgeous, absolutely
except
wonderful.
that the LED, distal LED is still a little questionable.
Yeah,
but rest looking good. Which we knew, but that's okay. We'll try to see whether it's a balloon versus what. Yeah. And remember, some of the small dissections, you go to a little low pressure.
You give 2.5 or 2.75 to the LED?
So this is just 3 or 4 atmospheres. How many atmospheres?
2.5. Stent was 2.5.
Yeah, but
balloon is 2.75 now. Huh?
No, this is in the distal segment where you are just putting. How many atmospheres are you?
It's clear. See here. Went to 4. Why the pressure went down? 4 and down to 2.
Down. Good. Okay, let's see. We have to decide whether we. Oh my God. Okay.
No, guide. 1 second. Let's see why the pressure went down.
Okay, nothing to do with it. Okay.
Yeah. Okay, pressure is okay.
It's time we finish this quickly.
The question is, do 1 stent extra versus you want to give a little nitro first?
No, nothing.
Okay.
I don't.
Go.
Just make a decision based on the angiogram.
Looks well. I don't know. You don't think there's a little bridging there?
It has become evident now.
Yeah.
Wasn't there before?
No, it was there. I think
it was there before. I had.
No.
You want to
on the top of the. Yeah.
Let's IVUS.
Good. Okay, we are okay now. Okay, let's take everything out.
I think it's a dissection.
I have to then look for a 2.515
stent. I'm taking the diag wire out. Okay.
Yep. Balloon and wire both out from the diag. Yep.
Okay, get us the IVUS catheter. And this is what we need to show. We are not a proponent of a pot in the non-left main. That despite no pot, we will show that it is fully expanded. Yeah, the proximal.
We have shown the paper. So this, look at this. LA diagonal is very nicely covered ostium. And so I think the distally will require, there may be still lumen compromise. But right now, rest of things look good. ECG is fine. Patient is okay. We are doing IVUS, and IVUS will be 2 purpose. We also see the distal left main. Okay. Yeah. So what is the MLD?
Distal edge of the stent and distal left main. Okay, long IVUS run.
And proximal bifurcation, whether it's fully opposed.
Yeah, well, it's fully opposed.
So that is the bifurcation club. There is a recent paper just came in Jack about new bifurcation issues. I have not read yet, but it made a lot of buzz apparently.
It's called the bifurcation issue. It is they have created a consortium, bifurcation consortium.
Some bifurcation consortium has been created.
Trying to make new definitions.
But we'll find out what exactly it is. Maybe I'll cover in one of our next our article of the month once it comes out, and I study it a little more. But I was told that it's there. So now question comes is that why this will not go. Because you want to put a second wire side by side?
Give me the fielder. Okay,
good. Went in.
No, it went.
So it was just the way you see how the guide is. I just had to reorient the guide.
All right. So it's time to bring in the Japanese expert.
Yeah. Kiski, a little louder.
Yeah. Here is no plug.
Good.
No plug is coming. A little bit. I can see some hematoma. Looks like this is hematoma.
Big dissection, no?
Yeah, I think back the balloon dilated hematoma, and this is the distal edge. Yeah, I saw that little bit hematoma there, and this is now intra stent, and stent is also a little bit elliptical shape.
Elliptical shape. Has not been fully expanded.
Yeah, but looks like not
It's
much
opposed but
calcium
not
as-
expanded. No, the lumen will be, that's keep playing, keep playing. Now let's see, are we at the left main bifurcation
Not yet, not yet,
Diagonal?
not yet.
Right
Still
there.
in your
Yeah.
stand.
We haven't even come to the
now I
dag.
see the bifurcation.
Now this is a
The
bifurcation.
diagonal
Yeah.
is coming from the 3 o'clock. And here's also a little bit
It is severe.
Flora? Flora for the left main.
Now it's left main.
It's a proximal LED. Yeah, now it's getting bigger. Yeah, look, the LED is big.
No, this is, you are in
This
the
is
left
the
main
left
now.
main.
Yeah, this is now.
You're back
left
into the
main.
left main,
Yeah.
okay.
I checked the distal left main area later.
Yeah, okay.
Okay,
good.
distal left main has a good.
Okay, I stop
Let's
lumen.
see. No, let's find out what the lumen is. I think the distal left main is tight. We'll see. But is it tighter than numbers? One by one. First we decide, do we need to put a stent in the mid LAD? That's the first decision. And secondly, the left main. But tell us about the distal first portion of the distal edge. After the stent, do we need to put a stent?
So now I see the circ from like 2 o'clock here. So I bookmark here. So I check the distal left main, just a little bit proximal over here.
Want to give some more medicine?
Okay, that's distal left main.
It's
Yeah,
true
good.
that there's a lot of
Yeah,
plaque.
it's
but
big.
looks the area
You don't need
is-
anything.
A second. Yeah, more than 6. This is the distal left main. So
Okay.
there's plaque, but area is more than 6. Distal left.
Okay, that was our goal. If it is more than 5.5, what is this now?
And this is the proximal edge of the LED stand, and go to the, I'll check the distal edge. It's a long stand. Yeah. So now this is just after the distal edge of the stand.
Yes.
There's like 9 o'clock to the 12 o'clock. I think this dark one is the hematoma.
Hematoma.
I think we should stent it. That's what my thought is looking at it.
Yeah,
Yeah,
knowing
no,
that now we don't have to do a left main. I
Come
think
to
we
the
can go to
prox LED.
2.5,
Give us a
15.
CSA of the prox LED.
Should. Prox LED.
Yeah, I think we have to go with 3.0 and expand it, right? Is it under expanded?
Yeah, proximal LED looks expanded. So,
Okay, good. Give us a CSA there.
Sure.
So Kiski may think that his biggest growth, having worked here with Sinai, has to be in imaging with OCT and IVUS. I think it is his English language which is the biggest gain.
Okay,
Yeah.
so the proximal LED cross section is a 6.3. So proximal LED is okay.
Okay, good.
6.5.
So we don't need to
Yeah.
expand the stent. The stent expansion you're happy with.
It's opposed, but is it expanded? That's what we're
Yeah, no,
asking.
6.5. 6.5 is okay.
No,
Remember 8.5,
barely.
6.5,
6.5.
5.5. Okay,
It's like
let's take a
6.1.
picture now.
It's
Let's take a
6.1.
picture first. One more picture.
SS is right now 6.1 prox LED.
Okay, let's take
Now
a
what are you doing?
No, one picture. So left main, I have to decide for the left main. If we are okay.
Nothing.
Yeah.
Okay.
Ready? And then we go stent in the mid LED.
LED
Circuit
looks good.
Compromise a little more.
No,
but
no,
that's
no,
okay.
no,
Yeah.
no.
Okay.
We
Go to
didn't
the
touch
LED then.
anything.
Go to the previous view. Okay. Let's go to previous view.
I think left main is you're good.
Yeah, right now it's good. Yeah. I'm okay for right at
What
this
about
time.
the
Yeah.
ostium
LED.
of the circumflex?
Circ. Yeah, little pinch. You know, it was always there. Little more pinch. Okay, here. Do you want to put a 2.5 here? That's the decision making. Here. See that? This will be always there. Although there is a little more decreased blood flow in the circ here. See that? Yeah.
To me,
Slower.
circ is nothing.
Okay.
I would
Okay.
leave it
Circ
alone.
is nothing. Good.
Yeah.
So let's go to the LED.
Focus where you're
Yeah.
supposed to be.
So 2.5, 15.
Yeah.
Okay. 2.5,
15 may not
15.
go.
Huh? Then which one? 12?
12 is good enough, right, Kiski?
The normal part is from the distal edge of the 12 millimeter. From
12
the
is
distal
good?
edge of the
Yeah.
stand. Yeah.
I would go 12. Remember this, like this may not
Okay,
go,
yeah,
and
no.
then we'll have to get a guideliner and
So,
all these
yeah.
things. Okay.
Okay.
Just side by side. 12
Yes,
is
yes.
gonna be the side by side.
Good.
Do you want to do 3.0 to the prox LED or no?
Yeah, we can do that.
Probably
Okay,
not.
I'm
right?
not worried about that. Yeah.
Okay.
Okay, so question is, do we need to a little more proximally?
No, I think
Okay.
leave it. Yeah.
The more important, we go to the mid. Yeah. Okay. So now with that note, do you want me to just?
Yeah, you start. You start. Go, go, go. We are done. We are going to put up place a short stent in a mid LED distal
Okay.
edge.
So we are going to do a stent in the mid LED as we expect a little bit of dissect.
And then we
Actually,
are
we
coming
need a
up.
long stent. Remember, there was a disease there. And to me, the stent where you do was not expected. That means it's usually not counted anywhere, but in my opinion, it's a procedural failure. But many times it is because of the length of the lesion. So stent was shorter than the length, then of course you have to put a 2 stents. So that's where the case was. So anyway, with that note, actually at present, we use about 4 to 5 balloon pumps and 10 to 12 Impella for high-risk PCIs at Mount Sinai. So 2 points. One is the recent international publications of the PROTECT 3 study, and second is PROTECT.
Okay, go.
It's not a spelling mistake. It's a PROTECT and PROTECT. And this is a QFR.
Good. Down.
A lot has been said about the
Okay, good. Down.
sex-related differences in the cardiovascular outcome, particularly emphasizing women, how to in terms of diagnosis, treatment, and I'm going to take this part only from our CAD point of view. So let's talk about very quickly the PROTECT 2 trial. Remember PROTECT 3 versus PROTECT 2. PROTECT 2 was our old trial, which showed at 90 days, Impella was a little better than balloon pump in these cases. Although trial was halted, but then they went to 90 days, was overall p-value was 0.08 in favor, but very complex endpoints, 9 of them. So then what we do now is that the appropriate cases, since then we learned quite a bit, and PROTECT 3 is the registry which were mandated by FDA to present all the cases which are done after the PROTECT 2 release. And they compare PROTECT 2 versus PROTECT 3 cases. Actually, PROTECT 3 cases are more complex compared to a PROTECT 2 cases, and these are the anatomic characteristics, procedural characteristics, revascularization outcomes. As you can see, that clearly we do better job now compared to what was done in PROTECT 2. This is the PROTECT 3. And this is the most important slide. That is the matched cases of PROTECT 2 and PROTECT 3. And these are the outcomes. As you can see here, in hospital and 90-day outcome propensity match. Every complication, MACI, MI, although stroke was not different anyway, repeat revascularization, acute renal dysfunction, vascular complication, bleeding requiring transfusion are significantly low in contemporary current practice compared to what we had. And it translated into better 90-day outcome compared to the cohort 2, PROTECT 2 cohort. Now, what are the guidelines? Latest guideline still remain class 2B. Why? Because only randomized trial of PROTECT 2 was stopped because of futility. Although we use it, but there is no level of evidence yet. So it's still class 2B. In our ACC guideline for European, still there is nothing in a high-risk PCI. Of course, there for cardiogenic shock, you can always use it. Then PROTECT 4 trial is ongoing, which is the trial of Impella versus control, which is a balloon pump or any patients with the multivessel disease, EF complex CAD with EF less than 40%. And the trial actually has enrolled right now about 150 cases, and Mount Sinai is like 1/5 of that. And endpoints are rate of all-cause death, stroke, durable LVED implant or heart transplant, MI or cardiovascular hospitalization at 3 years. And this will take few years, but clearly will answer this question. Maybe that time it will become into the guidelines. Now then, there are trial of radial artery occlusion potential preventive strategy. Patent hemostasis is of the central importance in the prevention of radial artery occlusion. Then there's a lot of data of the distal radial artery approach, snuff box access, lower RAO. So what happened is this trial looked into all these aspects. One, ultrasound guided access we know is better. Then your anticoagulation is better. C2 artery ratio less than 1 better. But then question is, and giving vasodilators, but patent hemostasis, which called lowest occlusive pressure, short hemostasis time, patency test, this has been propagated by many earlier trials of in the radial first and so. So their whole idea was that if you try all 3 of them, approaches, which is a PROTECT trial, was patent hemostasis, patent hemostasis with ulnar compression, and then hemostasis with a hemostatic disc. And what did they find? 500 patients in each study. Rest of the strategy was about the same, and basically found that overall no difference between 3 strategies. But patent hemostasis still have numerically lower event rate. So I think it remains that patent hemostasis should be the best treatment for these radial artery occlusion. So perfecting the end game, there's a very nice editorial. Now, then what about giving intra-arterial nitroglycerin called patents trial? It's a separate and basically found no difference. Again, large number of patients, 2,400. They gave nitroglycerin before and after and placebo and found no difference in the radial artery occlusion, of course, except that the nitroglycerin caused less vasospasm. I mean, those placebo was more vasospasm versus other. Then the third publication is the decision QFR. That is the angio-guided FFR called QFR versus randomized trial. Remember, we showed that favor trial presented a few months ago from China, favor 3 in Lancet, showing that QFR is very good. And here, decision FFR was basically the concept. Rather than you do invasive FFR, give adenosine or IFR, take some time, you go to each vessel, you can do based on the angiogram. And that we call quantitative flow ratio or QFR, which is the angiographic FFR. Basically these guys did the 260 patient, make a heart team discussion based on the QFR versus FFR. Very nice study done from Japan, and trying to see blinded whether what is the correlation of the FFR calculated by your angio, which is a QFR, or your invasive FFR, and basically found very nice correlation. Look at that. I mean, you cannot have better R of 0.88 and so. And then, of course, the functional syntax score as well as 10-year mortality estimate using both exactly identical, perfect correlation of two strategy. And also, there were recommendation that many times you have recommendation of PCI or CABG based on the QFR versus FFR, very high agreement of 90 plus %, substantial agreement as a primary endpoint, and of course, which vessel to be treated is also very much approved. Now, second is, by using QFR, it took less time, almost 4 or 5 minutes less compared to doing angio, which we understand because this is just taking angio views and software. So overall seems to be that this is a new device, actually they are available, 2 companies now, they approached us also. We'll be using that angio QFR in next few months, and they'll be coming for demonstration here. Second is sex-related outcome of gender. Particularly, there are 7 lectures with 7 publications with the initial introduction by Dr. Fusser and team. So 8 total lectures on this gender-specific outcomes. So what I'm going to talk about is medical, percutaneous, and surgical interventions for coronary artery disease with Roxanne Mehra and the senior author. We know that ischemic heart disease is totally different in women versus men. Lot has been written in terms of epidemiology, presentation, diagnostic testing, management. But a crux is that less women come to the testing. This is it. Medical care, access for whatever the reasons are. That has been shown that this is where the biggest drawback is. And of course, once they come, they have more comorbid conditions and have higher complication rates. So basically, some of the differences I have put it here, that the CAD presentation is at least 1 decade late, more obesity, atypical symptoms, and women are less likely to be referred for diagnostic testing, higher INOCA and MINOCA, which is ischemia versus myocardial infarction, and different pathophysiology. Dissection, Takotsubo, myocarditis is quite high, and all the antiplatelet therapy, the benefit is a little lower in the women because higher baseline and residual platelet reactivity, reduced benefit of aspirin primary secondary prevention, reduced benefit of potent P2Y12 in like ISAR React 5, lower reduction in LDL2 therapy. So all those are negative. Then PCI point of view, every study has shown some higher complication, but more importantly, long-term complication MACE worse in women compared to men, even if you take it to the newer generation stent, which are on the right side. So basically what has been shown is that the short-term, long-term in-hospital complications are much higher in women. Now, if you talk about the bypass surgery, look at the bypass outcome on the left side, single arterial or multiple arterial bypass, where there is a benefit of multiple arterial bypass in a man. In women, there is no benefit of you do one vessel or one arterial bypass or multiple arterial bypass. Why? Because offset by infection, external wound infections, and other comorbid conditions. Second issue remain is that the mortality at follow-up, look at this one, much higher in the women compared to men, after bypass surgery. So clearly, there are enough data to show there is a higher mortality after bypass surgery, not only short-term, even long-term. Although there was one Sweden study did show the men have a higher mortality compared to women in the after the bypass, but majority of them have shown that higher mortality in women post-op 1 and 5 to 10 years, higher in-hospital complications and wound infection, higher graft closure in women. So all different. And these are the very studies and going at present, men versus women for coronary artery bypass surgery. Some data have been shown and some will be coming up in the future. Now then, let's come back to the important point, and this is a very nice central figure. That one, high risk of vascular complication, what do you recommend? More radial. A smaller vessel size, make sure careful stenting, deployment utilization of atherectomy because of low calcium, higher risk of target lesion and target vessel revascularization, optimize just like imaging we did, higher risk of operative mortality following CABG, earlier access to surgery, technical expertise, get to the good surgeon, then high risk of heart failure, development of LV failure and after MI, same, recognition and symptoms, early treatment. Higher risk of acute kidney injury, routine implementation of nephrotoxic strategy, which we have shown, then utilization of guideline-directed medical therapy, more emphasis, and underutilization of multiple arterial grafting, which we know whether radial arteries somehow shown benefit in more women versus men. At present, in various levels, there are many trials are going with the CAD assessment, medical therapy, interventional, and CABG. You see that other intervention. All these trials are especially focused for women. Very important. Why? Because in all the randomized trial, women enrollment is anywhere between 15 to 28%. So unless you have a women-specific trial, will not have the answer. And this is where the trials will answer in the next few years with a women-specific for CAD. So now just to conclude some of them, gaps in knowledge and future direction, that clearly we had to identify the obstacles in the enrollment of women in the clinical trial, increase women representation as a PI, for the randomized trials and design trials exclusively dedicated to women, which I said. More important, societies should systemically collect and provide report to hospitals and physicians stratified by sex. We know the overall data, but has to be based on physician as well as the patient by gender difference. And of course, performance metrics you need to evaluate and implement, and more important, community outreach program. The patient-physician gender concordance also has shown that women doctors do a better outcome treating the women. Somehow some studies have shown that physician-patient gender concordance with better outcome in CAD treatment, including survival post-MI. And of course, the dissemination, implementation of knowledge, recognition of unique cultural bias, prescribing guideline-directed medical therapy, improve communication, asking women open-ended question, and improve education. Effect of CAD on women is very important to fill in this gap. So therefore, it has to be the whole, society has to work on it, right from the preclinical research to the translational to various clinical trials that to emphasize on this aspect. So therefore, let's come back to our take-home messages. Strategy to reduce radial artery occlusion. All three strategies were equal, except the patent hemostasis may be slightly favorable. Then angiographic derived FFR, which is QFR, which is better or identical to FFR. Then improve outcome after Impella currently, absolutely yes. Recent data have highlighted the biological and socio-cultural differences between men and women, and therefore every effort should be done to highlight the differential healthcare access and better long-term outcomes. So 3 questions. Following the false statement about the results of the PROTECT 3 trial compared to Match PROTECT 2, lower MACE, lower bleeding, lower mortality, lower TVR, high rotation atherectomy in the PROTECT 3. Answer is C. Mortality was similar, but everything else was better in PROTECT 3. Second question, about the decision FFR, false. QFR correlated well with FFR. QFR heart team decision agreement with FFR in more than 90% of cases. QFR decision to treat vessel agreement occurred in more than 85%. QFR predicted 10-year mortality estimate correlated well with FFR, and QFR calculation takes longer time than FFR. Answer is no. It's almost 4 to 5 minutes lower in the QFR compared to FFR. The third question, following statement is false regarding the strategy to reduce radial artery occlusion post PCI. Patent hemostasis has good results. Ultrasound guided access is recommended. C to artery ratio should be less than 1. Intra-arterial vasodilator has shown to be effective, and adequate anticoagulation is the key. Answer is no. So spelling, we just have to change that anticoagulation. That D, the vasodilator has not shown to be effective to reduce radial artery occlusion. With that note, I'll complete my presentation today.
Samin, excellent and most comprehensive presentation. I absolutely loved your discussion regarding genders, which of course now has already reached the guidelines. The central figure which you showed is spectacular. However, I do have a major criticism of this work. I think it has failed to capture what happens with STEMI. This is where our work with the Lumen Foundation over the last almost 2 decades shows. I created a community outreach program with Dr. Alexandra Lansky, known as GLOW, Global Lumen Organization of Women. And we realized that globally, when you take a look, particularly in poorer countries, women have far reduced access to healthcare for STEMI. They have prolonged door-to-balloon time, and we specifically found that it was related to cultural, religious, and financial barriers which women face. I think it is one of the most important thing. Of course, you know, there are issues of a smaller vessels and using more radial and better techniques with stents. But the fact that women around the world are not even getting appropriate care. I mean, this is our mothers and our sisters who are not getting appropriate care because of personal barriers in STEMI, I think is probably the biggest part, I think, which is missing in this entire discussion.
No, I did mention, remember, socioeconomic and cultural
Right,
bias,
right.
very important. Yeah, no, but it's more so for the STEMI, for anything. STEMI actually always has shown, as you mentioned, lower pain to door time, higher
Right.
in women. Same door to balloon time, higher in women. So many times, because they feel the symptoms are atypical and they don't get to the medical care. And secondly, their own bias. So I would say that people talk about the bias, but if you can't bring them to the treatment, what is the bias? Therefore, it has to go back down to the community level, educating, more emphasis on education of the female.
So much role of awareness and community awareness, as you mentioned. Excellent discussion. Anu, you have a follow-up for the patient in this case?
No, we completed, we've placed a stent.
Right,
You can
in
show
the
the final picture.
distal part of
and,
the LED.
And we have a final picture in the caudal. You see here?
Yeah. Go previous view.
Everything.
Yeah.
And the circumflex origin is unchanged.
We'll bring back.
Yeah.
We'll bring back.
Other thing, we were just wanted to complete this by showing our new release. Remember, people were talking about what is called as a device aid. Right now, what we have is a web, the web app, means the mobile app will be coming shortly. This is where we are. If you see the amount of devices that Cath Lab handles, the way we created it is, go to the next, that you start with the axis. You see that? You start with the axis, whether it be groin or radial. Then you talk about the wires, diagnostic wires. And after that, we talk about the various catheters, which includes diagnostic catheter, guide catheters. Then we talk about the wires, which actually will be, you know, related to our guide wire app. Then we talk about balloons, stents, and miscellaneous devices that are used in the Cath Lab. This is just to give you an bird's eye view of the amount that we have covered in this device app. Like we did in any other app, there's a small description to understand about each device, which company makes it, various characteristic of the devices. And there's a search function. You can go and search at various level all these devices. So this will be especially helpful for all the technicians, nurses, cardiology fellows, as well as intervention fellows. So you need to know your devices before you start doing any kind of complex work. So this is a device aid that is now available.
It's available now?
Absolutely. This will be remarkable work. Continued good luck. Samin, excellent case. Beautiful presentation. We conclude our program here and we'll see you on our next session on July the 19th.